One thing that I'll mention about the final is that we will start at 5 o'clock on Monday. So for those of you who can be here early, then be here early. That means you'll get out of here early. For those of you who cannot be here early, be here at 5:30, no harm, no foul. You'll have at least, I'm going to say, about 2.5 hours to complete the test. So normally you've got about 85 minutes, 90 minutes. For that test, we don't have to worry about anybody coming in behind us, so we have plenty of time. Okay, so, and I'll reinforce that when we come back on Monday night as well. Everybody knows about the review session we're going to have. There's the Framingham homework assignment that is due next Monday night. I'm going to come back and make a point about that in just a moment once I run through all these things. There's a lab that we're going to do tonight, which is a computer simulation of pressure volume diagrams, and is a very important way of thinking about how the heart works. So make sure you study the pressure volume diagram, and as I said right here, material from this lab will be on test number 4, but it would be there anyways. But the lab hopefully will help reinforce some of the things that you'll need to know. And with regards to the pressure volume diagrams, one of the things you need to be able to do is predict how certain pathological conditions will impact the shape of the pressure volume diagram. Now, a couple weeks ago, I put up some formulas for you talking about muscle. What do muscles do? They produce force, they produce length changes. That was simple. Then I sat there and said muscles produce work. And work is simply force times a change in distance or over distance. And then I talked about power. Power is force times distance divided by time. A different way of saying it, power is force times velocity. The work that the heart does is called pressure volume work. Pressure is a force. Volume is a change, it's a displacement. So pressure times changes in volume is work. The heart has to maintain a certain cardiac output. That demands that it be able to produce a certain amount of power. So we're interested in pressure times the change in volume per unit of time. And I'll talk about that more as we get into that. But as I said, these pressure volume diagrams are very, very important. There's a lot of stuff within them in terms of the opening of valves, the different phases of the EKG. And then, as I mentioned, I gave you a heads up, there's going to be a supplemental lecture, and there'll be homework based around this. Why am I having you do homework? Because I'm mean and ugly, and I want to work you guys to the bone? No, the homework is to reinforce things that could show up on test number 4. Hint, hint. All right? So if you can do the homework well, then you should be able to do any potential problems that pop up well. It's kind of like being a football coach, and we're at practice, and I'm making you go through drills, and then you show up for game time, and you're on automatic pilot, because you know exactly what to do. All right, a lot coming up. So, without any doubt, we've got this 5-step model, which I'm going to tell you, for those of you who go off into PA land, nursing land, nurse practitioner land, pharmacology land, it's probably one of the most important things you can learn. And I've had students come back to me year after year going, you know what, that 5-step model turned out to be incredibly valuable in my program. Why? Because the singular, most important story of human biology is taking oxygen from the air that we breathe and getting in the mitochondria where we can satisfy the energetic needs of all the cells in the body. So those 5 steps: ventilation, gas exchange at the pulmonary level, gas transport, gas exchange at the tissue level, and then last but not least, cellular respiration. So step number 3 is huge, because we've got all the factors that we talked about in terms of determining the oxygen content of the blood, but now we've got the cardiac output side of it, and all of a sudden you can see this algorithm over here that's blossoming in front of you, and there's tons of information to come with regards to that. Also, there's a lot of pharmacology in that algorithm over there. You will need to know the pharmacology for test number 4. You're probably going to learn, I'm going to guess conservatively, about somewhere between 12 to 15 drugs. Okay, so Monday night we got into determinants of stroke volume, and we got deep into what determines end diastolic volume. You're going to tell me that there are 3 factors that determine end diastolic volume. Filling time. There's stiffness of the walls of the ventricles. If the ventricles are stiff, they cannot fill up with a normal amount of blood. End diastolic volume will be down, and by definition, stroke volume will be down, and cardiac output will be down. And people who are in heart failure get this abnormal remodeling of the walls of the heart, and the walls of the ventricles get stiffer. So the heart failure they experience is not a failure of the contractile apparatus. It's a failure of being able to fill up with blood. And as a consequence, they're on this downward spiral. And that's why treating hypertension is just so darn important. As you guys go forward in your lives, you've got to be very vigilant about treating hypertension if you develop it. And probably somewhere around 40 to 50% of people over the course of their lives do develop hypertension. It's a silent killer. You don't know you have it until somebody measures it. Then you know you have it. But it's not like you've got a tumor sticking out on your skin. You go, oh my gosh, I got cancer here. It's something that's silent. The other thing I should mention, and I think I may mention this to you, hypertension is responsible for about 1/3 to 50% of all strokes. And I think I mentioned this. If I didn't, you'll hear it for the first time. 2013, my mom was just like any one of you here. She was 83 years old, fully capable of doing everything that she needed to in life. She had a massive stroke one night, and then she was bound to 24/7 care from that point on for a year. And if she could have looked down upon herself and seen what she was going through, she would have said, you know what, pull the plug. Because she never ever wanted to be in that situation. And it's a terrible thing to go through. Not only for her, but also for the family to see her that way. Okay, tonight we're going to transition and get into end systolic volume. There are 3 factors that determine the end systolic volume. The first is afterload. The second, why do I have, I'm not sure what, I've got the regulation of calcium second. The second is a Frank-Starling mechanism, and the third is a regulation of intracellular calcium levels. And that's going to take up a bulk of what we're going to talk about tonight. One thing I just want to emphasize to you that I pointed out on Monday night is some students get accustomed to seeing, oh, when EDV goes up, stroke volume goes up. And so without thinking about the logic, they simply go, oh, if end systolic volume goes up, stroke volume goes up. Remember, no, if end systolic volume goes up, that means you pumped less blood out during that cardiac cycle. And that means stroke volume is going down. Please don't miss any questions related to that. All right, now a quick note about the Framingham assignment. There's a lot of different ways in which you can do the plots, but here's my suggestion to you, is that keep yourself from having to make a gazillion plots. You could have one plot is for women. And I think there's, excuse me, I think there's 6 scenarios, 6 hypothetical conditions. And so you're going to have age, That'll be in years. And then over here, you'll have coronary heart disease risk, and this is percent. And you're asked to plot the data going from 40 years of age on out to 79 years of age, starting at 40 and then going up in increments of decades. So this might be your data for your normal condition. Might look something like that. So what I'm saying is you can come along and just simply plot all 6 of the hypotheticals for women in a single graph. So you can have 6 curves. And then you do the same thing for men. That way, you only have 2 graphs. I have had students who put 12 graphs on a piece of paper. But really what we like to see is a single graph where we can take a look at the incremental change that these various scenarios produce as a result of aging. Any questions about that? All right. Test question time. Ms. Rodriguez, what are the 3 primary risk factors for the development of heart disease?
Smoking.
There's 1.
Hypertension.
What's that?
Hypertension.
Good, you were listening.
And I don't know, but I would guess like high cholesterol or dietary.
High cholesterol, that's right. That's it. Come May the 20th, please don't walk in here and you see test question goes, what are the 3 primary risk factors for the development of heart disease? And your answer is blank. Please don't do that. Don't do it. I'm not saying that because everybody gets that question right. I'm saying it because some people don't. And it's simple, easy points, number 1. And number 2, being good health citizens, you should all want to know how you can optimize your health. Okay, here we go. So we're on this side of the equation now. One other thing. Number 4, where I put muscle activity, you could also refer to that as the muscle pump. And I like that because as I explained to you on Monday night, your muscles during activity do act as assist pumps, driving blood back to the heart when they contract. So here, just in parentheses, I'm going to put muscle pump. All right, afterload. Remember, afterload is really our diastolic blood pressure. So afterload is really just a term that's used to describe the force that the heart has to produce to get blood ejected out of the ventricle. And the point that I made to you, and let me just come back now here for a moment. Here's what we're saying right now, is that for women, our definition of normal blood pressure is going to be 110 millimeters of mercury over 70 millimeters of mercury. The number on top is the systolic blood pressure. The number on the bottom is the diastolic blood pressure. What is the systolic blood pressure? It simply is the peak pressure that occurs during systole. That's what it is, the peak pressure. there's diastolic blood pressure. Diastolic blood pressure, as I already mentioned, is the afterload. It's the pressure pushing down on the aortic valve. So the pressure within the aorta during diastole, excuse me, is acting in all directions. It's pushing forward, it's pushing backward against the walls of the aorta, it's pushing up here in this diagram, and most importantly, it's pushing down on the leaflets of the aortic valve. And so as I discussed with you on Monday night, during diastole, the aortic valve stays closed until the pressure within the ventricle is greater than this pressure here. So the hypothetical I gave you the other night is that the ventricular pressure is like 10 millimeters of mercury. What's the position of the aortic valve? Many of you sat there and said it's closed. That's the correct answer. If the pressure is 50 millimeters of mercury, and we've got an afterload of 70 millimeters of mercury, or diastolic blood pressure of 70 millimeters of mercury, what's the position of the aortic valve? Closed. If it's 69 millimeters of mercury, the position of the aortic valve is closed. As soon as it goes above 70, 70.5, 70.4, the valve opens up and now blood can flow out. That's our diastolic blood pressure. Now, I have also mentioned that to understand this, this is the force-velocity relationship. Mr. Giovanni, what determines the shape of the force-velocity relationship? Oh, big thumbs up. What else? What determines P naught? What determines the maximum isometric tension? Philip, what would your answer be?
Sarcomeres in parallel.
The number of sarcomeres in parallel, right? So those are the determinants of the shape of the force-velocity relationship. So we're going to come along. Now we're talking about the heart. We're plotting the force that the heart has to produce versus its shortening velocity. And we're going to come along. And we've got a curve that looks something like that. We're going to, just to reinforce these concepts, here's P naught. This is maximum isometric tension. This is the number of sarcomeres in parallel. And the maximal shortening velocity is determined by the type of myosin heavy chain isoform. Just for a hypothetical purpose, we're going to say that right here is the diastolic blood pressure. And we're going to say that that's the diastolic blood pressure, and this equivalent to 70 millimeters of mercury. That's the afterload. That's the force that the ventricle has to produce to get the aortic valve to open up. So what's the velocity that the ventricle is going to contract with? And the way we find that out is we simply draw a perpendicular line to where it intersects our force-velocity relationship. And this is the shortening velocity. Miss Javati, you did so well, I have to reward you. What's that? You said ask Simon?
No, she didn't.
I heard her, I could hear her. She said it very clearly from where I'm standing. Maybe you didn't hear, maybe you need to get an ear exam or something, hearing exam. Miss Simran, we have an individual who's hypertensive. We got Mrs. Jones. Her diastolic blood pressure is no longer 70 millimeters of mercury, but it's gone up now to, we'll say, 100. Very high, 100 millimeters of mercury. Where would Mrs. Jones be working in that force velocity relationship? I'll tell you what, you get to be the instructor for a moment. Come on up. Hey, I gotta keep it fun in here. I gotta keep you guys entertained. There you go. Let's see how well she does. Okay, ask the question of your worst student in the class. Very
Okay, Mr. Vince. Would the velocity increase or decrease if the DVP increases?
I think it's going to decrease.
I don't know.
Are you trying to trick me?
Are you trying to call Maka? Maka. Okay.
I have a question though.
Yes.
That's all good, but I'm wondering, how does that affect the stroke volume?
It's a great
Excuse me, the
question.
end systolic volume.
Let's Google that. The end systolic volume.
Yeah, you know, that's over here,
Okay.
Dr. Simon.
Okay.
So is blood flowing out of the ventricle at a faster rate or a slower rate?
It's a slower rate.
Ah, and so if it's flowing out at a slower rate, then that means more blood's gonna leave the ventricle or less blood?
Less blood.
So end systolic volume will go,
Down. Up.
you're a good teacher, I don't know. You just said, Dr. Simon, that less blood will be flowing out, so that leads me to believe that the end systolic volume will be going down as being your worst student.
Yes. No.
If less blood comes out, doesn't end systolic volume go up? And if less blood comes out, the end systolic volume goes up, which means stroke volume goes, which means cardiac output goes down. By the way, you did very, very good. It's time for me to quit now, and you can take over class next semester. So herein lies the importance of afterload, is that because of the force-velocity relationship, if the heart is having to work against a higher afterload, then according to this relationship, there's this inverse relationship between force and shortening velocity. And so as the afterload goes up, shortening velocity goes down, which means we're pumping blood out of the heart at a slower rate. That means less blood is going to come out of the ventricle during each cardiac cycle, causing the end systolic volume to go up. So here, in our hypothetical, using our algorithm, we're going to say that there's an increase in afterload. That then results in an increase in the end systolic volume, which causes stroke volume to go down, which causes cardiac output to go down. What do you think? Make sense? What do you think? Mr. Ramos, what do you think, Zane? Make sense?
Yeah.
Okay, you get to be teacher in just a moment. parastatically. How about the Frank-Starling mechanism? The Frank-Starling mechanism is the length-tension relationship. If you recall, if you go back in your notes, hopefully if you wrote this down, I said that there were two primary determinants for design constraints of muscle. The first was the force-velocity relationship, the second is the length-tension relationship. That was for skeletal muscle, and the same thing is true for cardiac muscle, because cardiac muscle, for all intents and purposes, is just like skeletal muscle, for the most part. So here, we've got the length-tension relationship. So to be clear, when we talk about the Frank-Starling mechanism, what we're really talking about is the length-tension relationship. Also, I can't remember if I wrote it up there, hopefully I did. The Frank-Starling mechanism is also known as the law of the heart. So make sure you know that as well. So on our y-axis here, so now we're talking about the length-tension relationship. So we've got percent maximal force. And down on our x-axis, we've got sarcomere length. Ms. Limpin, what would you tell me about the length-tension relationship?
How does the force sarcomeres varies on that? Like how does the force of the sarcomeres produces varies on that?
Yeah, so what's the shape of the length-tension relationship?
It can be ascending, plateau, and descending.
That's right, very good. So we have the three different regions. This is the ascending limb. And simply stated, in the ascending limb, as sarcomere length is longer, the force that the sarcomere can produce goes up. We then have the plateau region. And as sarcomere length increases, the force that the sarcomere can produce stays constant. This is the plateau region. And then we've got the descending limb of the length-tension relationship. And the heart can never operate in this limb. And why would that be? Because in this limb, as sarcomere length increases, force production goes down. Just put in a simple little drawing here. This is meant to represent the left ventricle. And we're going to say that this is at the end of systole. So here, I'm going to put an @ sign. I'm going to put ES, the end of systole. It's really important that you understand what's happening during the cardiac cycle. So here we've got our end systolic volume, and down here we've got our end diastolic volume. So here's the geometry of the left ventricle here. And now we enter into diastole. What happens during diastole, Mr. Reyes? That's right, filling, right? So we have ventricular filling. That's exactly right. So, just to help think about this, here's our sarcomere. Now we enter into diastole. And during diastole, the ventricle fills with blood. And we're going to say that this represents our end diastolic volume. And in this hypothetical, our sarcomeres have been stretched out. So now we're going to come to this diagram, and I'm just going to put a little tick here, and beneath this tick I'm going to write E, S, V. That's the sarcomere length that corresponds to the end systolic volume. Say it again. This point is the sarcomere length that corresponds to the end systolic volume. Now we go into diastole, and the ventricle has to fill up, so the sarcomere stretches out. And we're going to say that this tick here represents end diastolic volume. And at this end diastolic volume, is the ventricle producing its maximal force, or is it producing something less? What would you tell me? Can't hear you guys. Miss Megan, what would you say? So producing a maximal force or something less than maximal force? That's very good. She said submaximal force. Right? Here's the maximum force it can produce. At this end diastolic volume, we're producing something less than that, due to the length-tension relationship. Mr. Liu. I'm standing up, and now I go into a posture where I'm sitting down. I need you to look over there. What part of that algorithm over there has been affected by the change in my posture?
Would be the filling pressure? Filling pressure?
Filling pressure?
Yeah.
Why do you say that?
Because of the effect of gravity.
Fantastic. That's really good. That's exactly right. That's the beauty of this algorithm. He doesn't know what I'm going to say next, but hopefully he'll use that algorithm to figure it out. So we would say the effect of gravity has gone up, or has it gone down?
Gone down.
That's right. We say it's gone down. So I'm going to come along here, and I'm going to say that the effect of gravity has gone down. Tim, what's going to happen to filling pressure? Is it going to go down, or is it going to go up?
Would it go up?
It will go up. Logic 101. The heart's producing a certain amount of energy. If it's using most of that energy just to lift the blood back to the heart, there's less energy available to push the blood into the heart, to fill it up. So if I reduce the effect of gravity, now the amount of energy that the heart's producing, less of that's being used just to lift the blood back into the heart, which means there's more energy left over to produce a filling pressure. Yeah? No, maybe so? Yes, most definitely. So filling pressure goes up. And Tim, you're going to tell us what's going to happen to EDV.
It'll also go up.
It will go up. All right, now, here's where you got to put on your thinking cap. Is that the ventricle has filled up with more blood. How do I get rid of that extra blood? That's a really important question. Because normally, the ventricle and the sarcomeres are oscillating back and forth here. But now we've changed posture. And so we're filling up the left ventricle with more blood. And the question you have to ask is, how do we get rid of that extra blood that filled up the heart? Anybody? Don't be bashful. Are you? Go for it.
Is it because you filled it up with more blood, so on this relationship it would go further to the right, closer to the plateau, have more force to push it all out?
Okay, so here's what Mach is saying. He says that if we fill up the heart with more blood, we're going to stretch out the sarcomeres more, and we're going to move higher up on the ascending limb of the length-tension relationship. We'll test it out. Let's see what happens. So if I have a new end diastolic volume here, I'm going to write E, D, V prime. The force that the ventricle is going to be able to produce is going to go, what?
Up.
Up. And this is not the force production side, right? This is what's happening during diastole. The force production side is over here. So the ventricle is going to contract with more force. Here's the way I would ask you to think about this that makes sense to me at least. And that is, if you've ever washed your car, pretend you've got your car, it's dirty, it needs to be washed. You got this bucket filled with water, and you got this sponge. The sponge is the left ventricle. And you put it into the water, and it fills up. That's the blood going into the heart. And then you take the sponge out, and you squeeze it lightly. How much water is going to come out of the sponge? A lot or a small amount? Small amount. On the other hand, if I were to squeeze that sponge really hard, you would tell me that a little bit of water would come out or a lot? A lot. That's exactly the analogy we can use here, is that by stretching out our sarcomeres more, moving higher up on the ascending limb, the ventricle contracts with more force, and therefore you're going to tell me that end systolic volume is going to go, anybody? Stephen?
Down.
End systolic volume will go down. That's exactly right. Very good. Wow, look at this. Because of a reduction in the effect of gravity, I got EDV going up, and I have end systolic volume going down. The difference between these two is going what? It's going, Eunice says it's going up. Stroke volume is going to go up. Cardiac output is going to go up. We have to be able to get rid of this extra blood that fills up the heart. And, very importantly, we have to do it on a beat-by-beat basis. There's no sensor. There's no neural system that's connected with this. Instead, what's beautiful is that we have the length-tension relationship that is our beat-by-beat sensor, right? It's the length of the sarcomere that's being altered, and that alters the force that the ventricle will produce. And that's the law of the heart. It's pretty cool. It's pretty amazing. It's a miracle, to go back to where I started this class. We can never, ever operate here or here. If we operate here, and I stretch out the sarcomeres, am I going to get rid of the extra amount of blood? No. If I'm out over here, and the heart fills up with more blood, look what happens. The contractility, the force production doesn't go up, it goes down, which means on the next cardiac cycle, it's going to fill up with even more blood. And the next cardiac cycle, it's going to fill up on even more blood. And guess what? You end up walking out in this direction here, which is, yeah, it's no good, right? So we're always operating on the ascending limb, oscillating back and forth depending upon how much we fill up the ventricle with during each phase of diastole. Now, if there's an afterload, then you might wonder, where is the what? Where's the preload? So here's a really cool thing, is that the end diastolic volume is the preload, because the end diastolic volume determines where the sarcomere is operating on the length-tension relationship. So here I'm going to write preload. In class, anytime you affect EDV, by definition, you're altering the preload and you're altering where the heart is operating on the length-tension relationship, by definition. Let's just take a time out, quick time out, hopefully. Anybody have questions? You're confused, don't be bashful to speak up, please. Miss Lumpin goes, nope, I got it in the bag. I'm ready to do battle with you, Professor Simon, on test number 4. Did I guys tell you that she's she's making all the questions on test number 4. And she's a really hard instructor. I had her last semester, the semester before that, and this semester. She's tough. All right. Well, I'm glad to report that we have a new instructor in class, Professor Todd. Lisa's back there rolling around on the floor. Right now, Jonathan's going, why did I ever tell him I worked in the cardiologist's office? Is that why you weren't here on Monday night? You were.
I thought I tore my bicep tendon.
You tore your bicep tendon?
Yeah, I was trying to.
You strained it.
Strained it.
You didn't tear it.
Yeah.
If you tore it, you would be in a cast,
Yeah.
and you wouldn't be moving that arm.
Yeah.
Too much lifting in the weight room, right? Okay, so right over here. So here's the cell membrane of our cardiac myocyte, and all of you would tell me that the name of the cell membrane in skeletal muscle and cardiac myocytes is the sarcolemma. Within our cardiac myocytes, we've got the sarcoplasmic reticulum. I'm not gonna label these. I've got these ion channels in blue, just as I've tried to do all throughout the semester. These are voltage gated sodium ion channels. We've got voltage gated calcium ion channels. Those I'm showing in red. And we've got voltage gated calcium ion channels. And these I am going to label. And I should have left more room for myself up here, but. These also can go by a different name, dihydropyridine receptors. DHPRs. All of you know that within the terminal cisternae of the sarcoplasmic reticulum, we've got these calcium release channels. And these can also go by another name known as ryanodine receptors. And these oftentimes are referred to as RYR. So capital R, lowercase y, then capital R. If you recall, when I created this table to contrast skeletal and cardiac muscle, one of the points that I made is that in skeletal muscle we have this highly developed sarcoplasmic reticulum, which can release enough calcium out into the sarcoplasm so that we completely saturate all the troponin C. In the heart, the point I made is that the sarcoplasmic reticulum is moderately developed. It's not highly developed like we'd see in skeletal muscle. And the sarcoplasmic reticulum can release enough calcium to activate about 70% of the contractile apparatus. A different way of saying it is it can bind to 70%, approximately 70% of the troponin C. So we're not able, the sarcoplasmic reticulum normally is not able to activate all of the contractile apparatus. All right, so now it turns out, and also by the way, if you recall that in skeletal muscle, there is this protein that mechanically links the voltage-gated calcium ion channel with the calcium release channel. In cardiac muscle, that's not the case. So when a cardiac myocyte depolarizes and the voltage-gated calcium ion channels open up, calcium comes flowing in to this region between the T-tubule and the terminal cisternae of the sarcoplasmic reticulum, and it's the presence of this influx of calcium that causes this calcium release channel to open up. And we're going to call this CIRCR. C-I-C-R. And that stands for calcium-induced calcium release. So it's the influx of calcium through our voltage-gated calcium ion channel that causes the calcium release channels to open up. All right, so now we come over here, and under the regulation of intracellular calcium, what we're going to put is we're going to put calcium channel blockers. So we've got this cardiologist's office. We've got Mrs. Jones. She's been suffering from hypertension for quite a while now. And she comes to this new cardiology practice, and the doctors there identified that Mrs. Jones has a blood pressure. We'll really exaggerate this, of 180 millimeters of mercury over 95 millimeters of mercury. By the way, the name of this cardiology practice is the TA cardiology practice. And Dr. TA says, Mrs. Jones, you've got this chronic hypertension, we've got to treat it pharmacologically. I'm going to use a class of drugs known as calcium channel blockers. And what calcium channel blocker are you going to prescribe?
Amlodipine.
Okay, amlodipine. All right, I'm going to give you some others. That's a good one. So he said something interesting. The last part of that word, pine, right? Amlodipine. Here we go. Nifedipine. Nimodipine. These are two calcium channel blockers. And these are known as, these belong to a class of drugs known as dihydropyridines. What are dihydropyridines? They're a class of chemicals that block the voltage-gated calcium ion channels. So, why are we calling these voltage-gated calcium ion channels dihydropyridine receptors? Because there's this class of drugs that will bind to these voltage-gated calcium ion channels and block them. Here's another one. Verapamil. So we're just going to generically refer to these as calcium channel blockers. Dr. Todd, tell us how this new class of drugs that you've discovered works. And the answer is not there, the answer is over there.
It prevents calcium release because
It's gonna do what to calcium release? Is it gonna cause calcium release to be normal? Is it gonna cause it to be greater than normal or less than normal?
Lower.
That's correct. And will there be more calcium bound to tropin C, the same amount of bound to tropin C, or less bound to tropin C?
Less.
And therefore, force production will go down. That's right. Very good, Jonathan. So we treat Mrs. Jones using our calcium channel blocker. That, because force is going down, that's going to cause end systolic volume to go down. Mr. Ramos, is that correct?
Yeah.
That's what I thought. Ms. Sue, how about you? Oh, yeah, I'm rhymed actually. I'll bet you nobody's ever said that to you, have they? I'm the first person who said that. Ms. Sue, how about you? It's gonna go up. It is gonna go up actually, right? Because the ventricle's producing less force, which means it's gonna inject less blood. Don't let me trick you. So end systolic volume is going to go up, and that means that stroke volume is going to go up, right, Luis?
No.
No. That means stroke volume is going to go down. That means the cardiac output is going to go down. Well, what the heck? How do we connect cardiac output to blood pressure? Kai, how would you connect cardiac output to blood pressure? Mr. Vadi, how would you connect it? Okay, all right. Zane, what would you say?
I was thinking afterload and preload.
Okay, here's what I was thinking. I'm thinking that F equals delta P over R, or delta P equals F times R, and if flow rate goes down, according to this equation, then pressure will go down. That darn Ohm's law. Anytime we're talking about flow rate, you gotta be thinking Ohm's law. Anytime we're talking about flow rate of gases, of water through a hose, water flowing through the circulatory system. Water does flow through the circulatory system, doesn't it, Stephen?
No. Yes.
It does. What?
Yes.
Yes, it does. Because about 75% of our body's mass is water. That includes inside those little red blood cells. That includes in the plasma, right? Well, Mrs. Jones' sister says, you know what? She goes, this other office I was at, they also had me on a calcium channel blocker, and it didn't do anything to treat my blood pressure. Is there some other drug or class of drugs you could give me? And Dr. Toss says there most definitely is, known as
A different type of calcium channel blocker.
And Luis, you said what? A beta blocker, that's right. So we can give a whole class, a whole different class of drugs known as beta blockers. Beta blocker, I remember that from somewhere. There's beta blockers, yeah, because The heart is rich in beta-1 adrenergic receptors. The heart is rich in beta-1 and poor in beta-2. The lung is rich in beta-2 and poor in beta-1. And here's something really interesting, is that if you have somebody who's got asthma, do you want to give a generic beta agonist that affects both beta-1 and beta-2? And the answer is no, you don't. Because if you give this generic agonist that's going to act on both beta-1 and beta-2, I'm going to get the smooth muscle cells in the lungs to relax, but guess what? I'm going to cause heart rate to go up. The heart's going to be contracted with more force, and your patient's going to sit there and say, you know what? I can breathe better, but I'm kind of feeling a little weird. I'm feeling a little amped up. Okay, now. Miss Mia, can you help me out here? Here's a beta-2 adrenergic receptor, a beta-1 adrenergic receptor. Here's our sympathetic neuron. And this sympathetic neuron releases a neurotransmitter known as norepinephrine. Norepinephrine is going to bind to that beta-1 adrenergic receptor, and then what's going to happen? Ian? If you don't know, you don't know. But okay, Ms. Limpin, what would you say?
It acts on the stimulatory protein.
That's right. Very good. It acts on a stimulatory G protein. Okay, good enough. And then what happens?
Then it acts on adrenaline cycling.
Correct, good. Okay, and by acting on adenylate cyclase, we're going to have an increase in cyclic AMP. All right. And what comes after that?
It increases the level of
Say that again?
It increases the level.
No, it doesn't. We already got cyclic AMP going up, right? So this is going up, and what comes after that? Anybody?
Dephosphorylates.
There's a inactive protein kinase that becomes active. So I'm going to put I, P, K, inactive protein kinase, being converted into the active form of that protein kinase. And all you're going to tell me the protein kinases act on their target molecule and they phosphorylate it, and by doing that they change the structure of the target molecule, which is going to have some type of functional consequence. So this active protein kinase comes along and it phosphorylates this voltage gain calcium ion channel and causes it to open up. So what is that going to do to the levels of calcium in the sarcoplasm? Will the level of calcium in the sarcoplasm stay normal? Will it go down or will it go up? Come on, this is Logic 101, there's no tricks here.
Up.
It's going to go up, right? Calcium is going to come flowing into the cell according to the electrochemical gradient for calcium. That's going to cause an increase in the intracellular calcium. And if we have an increase in intracellular calcium, what's going to happen to the amount of troponin C that has calcium bound to it? And the answer is, that's going to go up, right? And if we have an increase in the amount of calcium bound to troponin C, then we're going to have what type of a change in force production?
Increase.
It's going to go up, right? So for all of you, one time or another in your life you were startled. And almost instantaneously your heart rate went up and you could feel your heart contracting with more force. How's that happen? Because that stimulus, whatever it was, caused a massive release of norepinephrine onto the heart, which then activates all this sequence of events. We have more calcium coming in to the sarcoplasm of the cardiac myocyte, and now the heart contracts with more force, and our end systolic volume is going to go up as a result, right? We think, Philip, is that right? So we're going to contract with more force, and that means our end systolic volume goes up.
Down.
Huh?
Down.
He's really checking me out hard there. He's kind of like, you know, like maybe I was a perp or something, you know. He's asking me like a question. Up against the wall, there you go. What are you doing here? Nothing. Come in, isn't it? Very good. Good job. So, end systolic volume will go down. Stroke volume will go up. Cardiac output will go up. Back in Dr. Ta's office. Dr. Ta sits here and says, okay, you know what? I've had a lot of patients come along and tell me those calcium channel blockers haven't done much for them. So let's put you on a beta blocker. So the beta blocker, instead of acting here, we're acting here. And remember, this is a beta 1 adrenergic receptor. So we're going to use drugs that are as specific as possible for beta 1. So when I say a beta blocker, what we're really saying is we're using a beta blocker that's very specific for the beta 1 adrenergic receptor. And so Jonathan, give me a generic beta blocker.
Metoprolol.
Okay, metoprolol. That's a pretty powerful beta blocker. That's a good one. Another one.
Carvedilol.
Carvedilol, yeah. So this is interesting. For the calcium channel blockers, we have the pene on the end. Nimodipine, nifedipine, amlodipine. So that's kind of good, right? Because it makes it easier on the student to kind of figure out where these drugs belong. For the beta blockers, we're seeing this ending lol or olol on the end. So we've got metoprolol, we've got carvedilol, we got propranolol. We've got Enderol, that's spelled I-N-D-E-R. Enderall. Here's 4. These are all beta blockers, very commonly prescribed beta blockers, and there's a ton more, and their use depends upon whether the individual's got arrhythmias going along with the hypertension, or they don't have hypertension but they got arrhythmias, and they could have very severe arrhythmias, where you use very, very powerful beta blockers that end up destroying your liver and causing you to die from liver failure instead of dying from heart failure. Somewhat of a joke, but not really. Okay, we still got some time. Good enough, we're gonna finish here. So, over here, under the regulation of intracellular calcium, we're gonna put beta blockers. So these beta blockers, just to come back, with the beta blockers, the heart, the ventricle is going to be producing less force, which means that it's going to be ejecting less blood out. That means that end systolic volume will go up. If end systolic volume goes up, then stroke volume goes down. That means cardiac output will go down. And now we're simply rearranging Ohm's law to solve for pressure. And we're going to simply think about it this way, is that we've got delta P is equal to flow rate times resistance. Q dot is our flow rate. And if that goes down, by definition, pressure goes down. All right, one last part to the story, then we're done. The scenarios that I've presented thus far are focused around treating hypertension. What if we have a heart that is actually failing? How do we go about pharmacologically manipulating that part? Well, way back when, all of you learned about the sodium potassium ATPase pump. So here's our sodium potassium ATPase pump. And, oh man, I'm forgetting so much stuff in my old age here. Jamie, you're up to bat. Help me out here, help an old man out. What's the concentration of sodium outside of the cells? 140.
Oh, it is 140, right? Millimolars.
Oh, come on. Come on, push back, don't. 140 millimolar, right? 140 millimolar. Good. What's the concentration of sodium inside the cell?
14 millimolars?
Good. Very good. Question for anybody, what's the concentration of calcium outside the cell?
1 millimolar? 1.
Ooh, 3 thumbs up for you. Very good. And how about inside the cell, Jamie?
0.1 micromolar.
Fantastic. Well, why do I even talk about calcium? Well, because you also learn, not only did you learn about primary active transport, but you also learn about secondary active transport. And one example of that was the sodium-calcium exchanger. Point I made before, the sodium-potassium ATPase pump is responsible for maintaining this concentration gradient. That's point number one. Point number two is that anytime we have a concentration difference for anything, by definition, there's energy stored in that concentration gradient. Point number three, that energy can be used to do work. And in this case, sodium flows from outside to inside the cell via the sodium-calcium exchanger. So the sodium concentration is moving towards equilibrium. The first law of thermodynamics says energy is neither created nor destroyed. So what happened to the energy that we lost from our sodium concentration gradient? And the answer is it's used to pump calcium out of the cell. All right, so we've got this individual, Mrs. Jones. Now she's suffering from hypertension, but she's got heart failure. We've got to do something to try to improve her end systolic volume. This is the filling side. This is the contractile side. So I'm trying to think about what's going on here. Filling, contractile. We've got to fill the heart up with blood, but then we've got to push that blood out. The pushing part's here. The filling part is here. So, we can come along and we can use a class of drugs that poisons some, not all, of the sodium potassium ATPase pumps. And by doing that, we change the sodium concentration gradient so that there's less potential energy in the sodium concentration gradient. And if there's less potential energy in the sodium concentration gradient, that means, by definition, there's less energy to move calcium out of the cell. So that's going to cause the concentration of calcium inside the cell to go up. If the concentration of calcium inside the cell goes up, then we have more calcium that can bind to troponin C, which means that the ventricle will be able to produce a normal amount of force, less force, or a greater amount of force. Greater amount of force. So the ventricle is going to contract with more force, and that's going to cause end systolic volume to go up, right? Yeah. Because if the ventricle contracts with more force, if that's going up, then end systolic volume's got to go up.
Down.
Down would be the correct answer. That's exactly right. So we can come along and we can treat the heart using a class of drugs known as cardiac glycosides. And Jonathan, give me one. Starts with a D. Digoxin. There you go. Digoxin. So for hypertension, we can use calcium channel blockers, we can use beta blockers. For heart failure, we're going to come along and use some version of a drug that falls into this category of cardiac glycosides, and the name of one of these is digoxin. So you'll hear that people sit there and go, yeah, I'm on dig. What they're really saying is they're taking digoxin or digitalis. And these are, I'll just mention that dig is in this class of the top 100 drugs as identified by the World Health Organization. Yeah.
So are cardiac glycosides the third?
Yes, thank you. Yep, thank you very much. So over here, under 3, we're going to put sodium, potassium, pump. And so underneath that, you're going to put cardiac glycosides. Well, I went over by a couple minutes. I apologize. That's it. See you guys up in lab tonight. As I said earlier, tonight is going to be a computer simulation. There's a fair amount of work you're going to have to do. I'll give you an intro to that before you get into the lab. And tonight's all about what's referred to as pressure volume diagrams. Everything I've described for you in terms of the cardiac cycle fits into these pressure volume diagrams, and I'll try to highlight that for you before you actually begin the simulation. So that, I'll see you guys up there in about 18 minutes or so. If you got questions, comments,